First of all, thank you, Chairman. Thank you, UEG. Thank you, all the audience, for being here. I try to express my point. I have to say I'm quite disappointed for what I've heard, because I'm not here judging how you perform in EST and which are the right indication. I don't like endoscopists with no experience with transendoscopic microsurgery to say which are the indication of TEM. The slide that has just been reported contains a lot of, let me say, not exact information that I would like to discuss later. But let's go quickly through my slides. There is no discussion that anything that can be lifted and cut in one piece with sufficient free margin should be. I'm not here assessing that surgery is always the indication. But we cannot, and you should stop, because we cannot distinguish benign from malignant. So piecemeal EMR is not a wise idea. And ESD fails in block R0 resection in at least 1/4 of the patients. And I'm giving you data now. You will tell me probably that this is out of date. But in my opinion, and with all the respect to all the Dutch people that offers us continuously country-based studies that really give us the mirror of what is happening in all European countries at least, till the very outskirts of every country, the main finding of the study, in my opinion here, is not the conclusion of the study, but the finding that 13% of lesions that were considered benign turned out to be malignant. Full stop. Any analysis, in my opinion, any further analysis is out of any sense. And they were excluded post-randomization for these reasons, which is also against the intention to treat principle, basic in science. Second point, EST fails in block R0 resection in at least 1/4 of the patients. There is lots of literature that proves this. There is a meta-analysis in European centers that proves that without considering any inferior limit, R1 resections are reported in 29% of the cases. If you include only cases larger than 18 millimeters, this raises to 35. If you include over 2 centimeters lesions, that should be the undiscussed limit for ESD, this raises to 38 and to 47% of all the considered patients, 1 out of 2. Now, why there is a big difference between European series and Japanese series? I'm not here saying that they are much more skilled than us. This is obvious. But there is also a report issue there, because in many Japanese reports, even lesions much smaller than 2 centimeters are included. If you look at this paper that is considered by all of us a Bible in the field of ESD, the 10 centers that contributed to this paper included all lesions smaller than 2 centimeters. There are even 2 centers that included lesions as little as 3 millimeters. Why do we assess the R0 resection rate based on this data? It doesn't make sense to me. Do you think you can really have an R1 resection for lesions smaller than as small as 3 millimeters? I don't think so. You should exclude them from this analysis. Now, we are focusing here on the rectum, and the only outcome that we should take care is the benefit of the patient. So we have to do the best to avoid what it is considered a subsequent need of radical surgery that entails bad quality of life. This is a devastating option for the patient. And even ESD here represents a risk compared to TEM. And the only available data that makes sense, unfortunately, comes from an analysis that I did, thanks also to Yutaka that contributed to this, that I know it's updated, out of date, but it's the only available today, unless you believe to a small trial that interestingly reported 96% R0 resection rate in both arms, something that was unprecedented in the literature before. So excluding this case, here what you see is that if you perform an EST in the rectum, you offer your patients 4 to 5 times more the risk of having radical surgery. Radical surgery means in 50% of these patients a stoma. Now, I've always been addressed that TEM is considered an overtreatment. Why is it an overtreatment? Today I've heard also ESD is starting to be addressed as an overtreatment. Now, I think that the definition of invasiveness is that anything that is involving entry into the living body, as by incision or by insertion of an instrument, cannot be accepted as definition of invasiveness. The patient that comes to you wants to have no scars, no pain, low complications, and possibly early recovery. This is the 4 things that he's asking to you, to be cured this way. And what you see here is a TEM, sorry, the video is not running. So this is a TEM performed, as you see, in spinal anesthesia. The face of the patient shows that he is not intubated. And there is no discussion, no anesthesiologist would accept to compare in a study spinal anesthesia with any deep sedation. Spinal anesthesia is by definition less invasive. So I think that TEM has an advantage over any endoscopic technique that entails 2 hours procedure and require deep sedation. But if you're not happy with it, I think I can show you now with great satisfaction what I consider the next generation of transanal endoscopic microsurgery. This is the first tool that allows to perform ESD that I'm convinced, should be the option in the vast majority of the cases, although you can transform it into a full thickness excision possibly during the procedure if you're not happy. Now, this platform called FlexRobot comes from the US, MedRobotics, allows you to ignore gravity. So you can advance it in the rectum and over, so far not more than 20 centimeters from the anus, and allows finally what it is missing. I enjoyed very much to see your rubber placed taken from the dentist and sticked on the opposite side of the rectum and on the colon. But you cannot compare that solution with tissue manipulation. And you don't have to deny that endoscopists are struggling since 2 decades to have tissue manipulation available. But this is technologically difficult. This is the first platforms that allow to do it, and not only allows to do it, but also allows to have bipolar coagulation on your right side, right hand, and driving with the Delta robot, the endoscope inside the bowel, it allows to position the system in a proper way that can allow robotic endoscopic submucosal dissection. Now, I heard with interest this morning Michael Burke commenting very roughly that this is something that is not needed. Well, I'm considering myself still in the learning curve. I performed so far only 25 cases. I had the pleasure to have the flexible endoscopist of the Cleveland Clinic visiting me last month, and he was astonished by the ease of use of the system. I am not here discussing that Yutaka could do exactly the same things, probably in the same time or in a slightly more time than I'm doing it, but this is my 10th case. And I'm able to resect lesions 8 by 8 centimeters in less than 2 hours without need of any suture in the end. But the interesting thing, and I'm concluding, this is the end of the dissection, okay? This is the end of the dissection. So in the end, what I can do, I can offer a real suture to these patients. And in case I'm not happy with the submucosal dissection, and here is the suturing, and in case I'm not happy with submucosal dissection, I can either start with full thickness or I can switch to a full thickness procedure during the procedure, like you see here. And again, sorry, but for time concerns, can you please? Okay. I want to show you now, this is the end of the full thickness excision, and just after that, I retrieve the specimen and I can start my suturing. Of course, I take advantage of braided suture, but you will see in a moment I can advance. This is in the upper rectum, so I can reach it with the standard straight instrument. I can advance a standard needle with a 15 centimeters long braided suture with a hole at the end, and I can close the gap. I advance the endoscope, I stitch full thickness, I retrieve the needle. You see the hole here in the end. I can adjust the needle on the needle holder. I come back and I go on this way. And I can do the same also in any case during an EST. I run the risk of having a perforation, which is, in my opinion, no discussion, the best way to get rid of complications. So let me conclude my speech. I hate this. Sorry. I have a Mac and I don't know how to use the trackpad on a PC. So you see, I'm starting the suture here. And this is the final stitches. I entrap the suture on the continuous suture. So to block it, very easy, believe me, no need much of a training like for an EST, and this is the final result, and I think it's quite convincing that this is probably preventing any leak, any bleeding, and probably also preventing recurrence the way we treated it. Thank you for your attention.